There needs to be a primary care network whereby majority of the cases would be seen at a level 2 and 3 facility. Level 2 and 3 facility, if thought, the levels of hospitals or health facilities are classified according to several things. The first thing is maybe size. The second, but most important, is the level of personnel who are in that facility.
Welcome to the One Health Lens podcast, where we talk about public health, global health, and more importantly, the road to universal health coverage. I'm your host, Dr. Diana Wangari Gitao.
And I am Dr. Simon Moshara Kigondu.
Today we'll have a slightly different conversation. It's really more me talking to Kigondu here and understanding he's been traveling around the country, meeting important people, attending very important meetings like yesterday, and just hearing what's happening, right? Because from where I sit, I still have questions that my mom is asking me, my grandma is asking me, everyone is asking me questions that I don't have answers to, right? Kigondu, what happened yesterday? Where were you? I couldn't get you on the phone. Where were you? Tell us.
Thank you very much, Diana. But I think you have been seeing what has been happening in terms of healthcare financing of this country and the new direction that the government has chosen to take on the road to universal health coverage. So yesterday we were at the Kenyatta International Conference Center, and we are participating in a meeting dubbed validation of those social health insurance fund regulations. And what that means is that in October 20th, I think, the social health
universal health coverage
bill, the social health insurance bill became an act. And it created a body called the Social Health Authority. The Social Health Authority has been charged with managing 3 funds. The Primary Healthcare Fund, the Social Health Insurance Fund, and the Emergency and Chronic Illness Fund. 2 of those funds are tax funded, meaning they'll be getting money straight from Treasury. That is the Primary Healthcare Fund and the Emergency and Critical Care Fund and Chronic Illness. So those 2 will be like getting tax funding directly. The contributory one is called the Social Health Insurance Fund, which in a way replaces the NHIF. NHIF used to be contributory, and the contributory aspect of this act is the Social Health Insurance Fund. So yesterday, after the act was passed, then after an act is passed, you need to have regulations on how to operationalize this act. So we have been giving input into this, and yesterday, the draft of the regulations that has been corrected and input that we, even as Kenya Medical Association, we gave a memorandum to the same. We're going to check whether our input has been
documented,
has been put in there. And some of the issues have, others are compromised on and off, but yes. So that's what we were validating. So it's part of public participation. And we also gave feedback on some of the aspects that we thought may need to be looked into.
I mean, all that sounds interesting. Very interesting. But those are not the questions my mom is asking me. You know, how many episodes? We've had a few episodes of this road to universal health coverage, right? And we started off, I think, on a good note, right? We were talking about practical issues. We had Wangari here where we talked about, a hard time during internship, which is pretty much you are thrown out into the deep end, right? You have to balance between what you studied versus what's on the ground, right? And I almost feel we have gotten to that point whereby, yes, we can talk about regulations. We can talk about, this was the act, the bill, and whatnot, right? But fundamentally, the question comes back to, we have to register fresh, right? We are registering March to June, right? We want to receive quality services. There are going to be deductions. But at the end of the day, if I'm sick, I'll have to go to a facility. I want to know that if I go to this facility, my SHIF card, right, is going to be accepted, right? I want to know, there are certain basic questions that now I'm even hearing. There's an element of, I cannot now present just to any facility. I'll have to first go to a dispensary, right? So maybe to be lenient, let me start off. In the regulations, what were these the questions you're discussing? Was this the feedback? Is that what was being discussed?
Thank you, Diana, again. I think we complicate issues.
Yes.
So what we need to do probably is now to start from the end. So you have a Kenyan.
Yes.
Who maybe is unwell. What can we use as a disease?
Either a cough, a cold.
A cough.
Yeah, a cough.
So let's say they have a cough.
Like the one I have right now.
And they go. They go to a facility. So what the act portends is that first there are some conditions that will first be seen at a primary care unit. What they are calling a PCN. There needs to be a primary care network, whereby majority of the cases would be seen at a level 2 and 3 facility. Level 2 and 3 facility, if thought, the levels of hospitals or health facilities are classified according to several things. The first thing is maybe size. The second, but most important, is the level of personnel who are in that facility. Just to make it simple, level 6, the highest level, is where you have the highest concentration of specialists, biggest number of like specialist cadres and specialized services. The lowest level of a health facility is like a level 2 is a dispensary. So you may find that it's run by a nurse, and the range of health activities in that facility are less than the higher levels. You may go higher and find facilities run at higher levels. So the main, so they have been divided into two. So primary health care fund will take care of level 2 and 3, that is dispensary and the health facility, health center. And then now SHIF, or social health insurance fund, checks in when you are in a level 4-5 facility. The fund has gone further to even emphasize on prevention. So there are some activities that have been put at a community level. Now community is put as level 1. And hence the promotion of what are called community health promoters. Previously community health volunteers, community health workers, but those are people who will be trained and they will be able to probably identify people within the community who may need health services and refer them. So that is what is happening. So if you have a cough, you go to a facility. We now go to the part of the facilities where the social health authority there is deemed to be an exercise which will be done again to classify these facilities. So then the classification, the Social Health Authority will now be able to say this is a level 2, 3, 4, 5. The Kenya Medical Practitioner and Dentist Council has classification of these facilities. I suspect they may use these classifications with probably some form of verification, because there was also an issue of probably some previous classifications. You hear of all this noise of some facilities that are they really level 4, 5. So they have a lot of work to do.
Kigondu, forgive
we are
me.
still at the cough.
We're still at the cough. I have a cough.
If you have a cough and you go to Kenyatta National Hospital, you will not be seen. You will be told to go to a level 2, 3. I
don't know what a level 2, 3 is. That's my problem.
So the Social Health Authority has a lot of work in educating Kenyans on one, when they are sick, what to do. This is part of the work we are doing now. We are also helping them identify. So level 2, 3s will be there, but a lot of them are the dispensaries and the health centers. But this also does not discriminate between, like previously, public and private. You can actually enter any of those facilities.
But now, okay, let's go back to this cough, right? What I know from my end, I have a cough, right? Let's even make it worse. It's not just a cough. I have a fever as well, right? I have other symptoms that I'm thinking I must go to a facility right now. It's not technically an emergency, but I'm genuinely not feeling well. I've tried even things at home. Typical story, right? I've done my dawa, it's not helping.
Yeah.
So what I know is I've been contributing. I will go to the nearest public facility before we introduce even private facility, because remember, we're transitioning. Unless it's clear that now I can walk to any facility, I will first go to a public facility, right? Unless what we're saying also is that during registration, this period between March and June, we're going to go register and be told that this is a pamphlet, or we sit all of us under a tent and we're told, hey, now that you have registered, you're going to start with a dispensary, and all dispensary will be blue. Then the next level will be wherever, all of them will be pink. So, things like that, because fundamentally, regulations will tell us, yes, this is how we're going to enact, this is how we're going to pay for whatever it is. All those are well and good. And at some point, we can even go into the details. But fundamentally, it will boil down to, if I do not know, I will find myself in chaos, because I'll show up. The administrators in the facilities are going to be overwhelmed, because come July, it's July, I'm assuming, after we've registered June, July, we go to a facility. People are still getting sick, right? They will show up. If people do not have that information, what happens? The guys at the facility are not going to turn educators. They want to treat. They want to treat patients. That's why they're there, right? At the same time, we also talk about these facilities will be overwhelmed by they used to see there 100 patients. 1,000 people are going to show up. And then they show up. We still have 5 nurses, 2 doctors, whatever staffing capacity the facility will have at that point in time. Do you have enough staff? It's not clear, and that's my worry, that at the end of the day, we're having so many meetings, and I'm not even invalidating those meetings. And I'm encouraging you to continue going for those meetings. Maybe you should invite me for one so that I understand, right? And I'm not even invalidating the spirit of universal health coverage, right? My issue from this other side is whenever anyone stops me and asks me a question, right? They're not asking me about bills. They're not asking me about regulations. They're asking me, when I get sick, what's going to happen? Even medics themselves, doctors, nurses are wondering what's going to happen, right? Because if one, it's a factor of we're going to have more patients who potentially, if they come to us where it was a dispensary and they're coming to us with conditions we couldn't handle, we couldn't treat at a certain point, right? Are we going to have to refer them? Yet in that time, they're moving from point A to B to C to D, right? What's happening?
Yeah, those are very good questions. And actually, for the social health authority, my advice would that they actually need a dry run. Dry run, which is exactly what you're doing now. But ideally, provision of health services is premised on availability of health facilities, availability of the requisite providers of healthcare to provide quality service. So it's premised on that. And it's also premised on that knowledge that you, as a mwananchi, would know where to go in case you fall sick. That said, if this cough person of ours goes to a level 2-3, one, they will have to verify that one, they are paid up, that they have are members of SHA, and the social health authority has in the regulation say that undertake registration of all 55 million Kenyans.
Okay,
so
how many voters?
So that's registration. Even a newborn is supposed to be registered within, some days or into the, so that you are eligible to the benefits. So one, it will mean that whatever identification you'll use for, then you are seen at the health facility. They check up your and say, okay, this one is can be treated. Then you are seen. If they are able to handle your condition, then you'll be treated and sent home. Well and in. If it's level 2-3, then the health facility will invoice the social health authority. The social health authority will send the claim to a claims manager who are, as that one of the regulations has said, there would be 8 claim managers across the country. They divided the country into zones and a claim manager. So when that invoice goes, the claim manager will deal with it and say it's payable, assuming. If they say it's payable, then they send back to the social health authority to pay the facility.
Wait, so... Okay.
I mean, it's pretty straightforward. It's exactly what NHIF
used to do. But then...
So, if the condition is not treatable and the people in the level 2-3 think that this needs to be sorted out at a higher level, maybe where there is a doctor or a specialized doctor, then they will refer you to a level 4 or 5. I'm sure there will be some documentation to the same. And it used to be there a long time ago where there was a referral maker. So you're still coughing. One has been treated, one has not been treated, right? So this one has been referred to a level 4-5. Now, when you go to a level 4-5 facility, then again, you'll be show your identification on the card, social health authority card. And then they will say, okay, this one is up to date, has been paying their dues. They can utilize SHIF, which is the Social Health Insurance Fund. Then they treat you and do investigations and things like that, and you get treated. If you need investigations, then they'll also send you for investigations and you come back. In those regulations, there's a list of what can be paid for by the package, so to speak. It's called a benefits package. See, so with your cough, you maybe in your benefit package there is X-ray, there is lab test for sputum. Let's say because in a PIMO, it may be defined in that benefit package. Once you come with that, then they treat you. Maybe the medications are in your benefit package. They're right for you.
If they're not, I go buy it.
So if they are not, those things that can be paid by the Social Health Insurance Fund, and they're in the benefits package, what is not there, then you would need to pay yourself. And how do you pay? There are people who may have additional insurance, private insurance. Then you can now activate a private insurance. There are those who don't have, and therefore they would need to add what is called a top-up. So it would be an out-of-pocket payment.
But, and again, I am not anti-UHC. I'm not anti-even. I understand it's a journey, right? My big issue is, first, most people are not aware of what's going to happen. There isn't enough communication, enough education, or at least we so far are still focused so much on the technical, on the political. The education is missing. Because the other question that is coming up is, even as you're speaking, right? You talked about claims being paid, all this. You always see in the headlines, you always hear of people who show up when they had NHIF, right? That facilities have not been paid, right? And so if you are under NHIF, right, you'll have to pay cash automatically, whether you've been contributing or not. We saw even in this past year, where there are some facilities in the country that were mandating patients to say you must first pay. It's not about NHIF, pay. Right? Because then the reasoning, and it's genuine, that if we have not been paid as a facility, we have millions, billions for some, right, that have not been cleared. We can't continue as such, right, until something is paid. Then in this case, the bills from the past haven't been settled from what I understand, right? What then will make me as a private facility or even facility provider, healthcare facility owner, right, to accept, right? That's not clear to me, right? Maybe, and again, it could be from a point of lack of information, right? Maybe there is a plan that will then make sure that facilities open their doors, right? Because if you owe me money, right, and you call me tomorrow, I still lend you money, I will not lend you money, right? It's simple, right? And again, all this, it's a conversation because it's questions people are wondering. It's questions as I'm listening, I'm wondering, okay, is this clear? And I'm asking you again because you're in the meetings. I think I'm campaigning to be in these meetings at this rate, but because if facilities are not paid, that's not clear, right? People are going to be apprehensive, right? Again, we're contributing. The apprehension around contribution, I don't think it's so much about me being deducted or even contributing, whether I'm salaried, non-salaried. It's not it. If I knew I was contributing 3,000, 5,000, whatever the amount is, and I know it's clear I will get services, it's not a problem. I mean, how many countries in the world have higher tax rates than we have in Kenya, but they get the service they pay for, right? Tax-funded services are tax-funded services. It's not clear. And also, we're coming from a past. We have a history whereby the past showed us that we've been contributing, we're not getting it, right? We have doctors who mostly are concentrated in urban centers. How are we now going to say that referral, I have to first appear? And it's a good model. I am all for primary care networks. I'm all for it, right? But if we're not clear about the staffing, that if I need to refer to a level, wherever the pink colored facility as it will be, right? If we're not clear that we'll have the doctors, it's not everyone to come to Nairobi. In those networks, are we going to have the surgeon there? Are we going to have the gynecologist there? Is that clear, right? And maybe we are putting the horse ahead of the cart. But if that's not clear and we say we're rolling this out, again, I foresee chaos, and that's what I'm worried about. You're talking about a dry run, right? Has there been an phased out approach when you're passing the regulations, right? I understand were there timelines?
1 year. So when the Social Health Authority was created and the Act was passed, then NHIF have 1 year to hand over. There's actually a transitional team to see how to transfer what was in NHIF to the Social Health Authority. Yep. And there's a team that has been constituted and they are working on it. Now, what I granted, like a lot of apprehension is coming from the debts that are owed by NHIF. lack of payment by NHIF has caused a lot of distress to a lot of health facilities. The advice that has been given and are that, by the way, the Social Health Authority will take over all the debts of NHIF.
Okay.
But the advice that we gave is that no, they need to clear the debts before we move to any other authority.
Any new authority.
And that is what a lot of people have been campaigning for. And there's a lot of push towards payment of debt. And this has been a bit tricky because there are some debts that had even been closed from 2017 in a different system. The system had changed. And that is a push that is happening. That said, a lot of health facilities run on NHIF, especially in the rural areas, a lot of the smaller facilities. And when you deal with NHIF, you're dealing with a contract. So contract means that you have agreed certain specifications. And if, for instance, you're not being paid, then you have recourse to a contract. One of the difficulties that we had at NHIF is that there was nothing you could do to them in terms of if you are not paid, what do? You complain to Parliament, you complain to, but still you are not yet paid. One of the advantages that these new regulations have done is that they have actually put in the regulations and in the Act a dispute resolution body of this chief.
People we can complain to.
Which is someone you can complain to and something can be done. With previously NHIF and other providers, you complain, but really it's the same. It's almost like the same people you're complaining to are the same people who are supposed to act. And probably that's a good thing and it's an advantage. When it comes to service provision, as I said, these are healthcare financing model. It's premised on availability of all other infrastructure, like the hospital should be there. But there was a parallel bill that was passed called the Facility Improvement Fund, FIF, which was saying that if this facility, a public facility, generates this amount of money, then the same amount of money will go back to that facility to improve services. So it is envisaged that facilities will actually be creating, will be getting money to be able to resource themselves over and above
what they receive
from above, so to speak. Human resources for health is, and we had Professor Frank Wafula here the other day. It's at the Kenya Human Health Resource Advisory Committee, KHRAC, has the Kericho Declaration that we are still we are monitoring. They made many resolutions, about 17 of them, and we hope that what they are doing now is improving the human resources for health at all public health facilities, so that when the shift takes over, then there are people to treat you. You see, so those are parallel things. So people sometimes tend to mix all these things together, and it gets lost. So sort of we've taken an approach like let's do one by one. So yes, this financing, how will it be done? The primary healthcare fund, the person who presents with that fund, that will be paid from exchequer. So you, ideally what they have said, you may not necessarily have been contributing, but that can be paid for. The services that need the social health insurance fund to pay, then you needed to have contributed. The third fund, which is the emergency fund and chronic fund put together, is addressing the right to emergency care and the right to health, which previously what used to happen is that if you are taken to a facility and no one is paying for you, then they'll cobble you up quickly and refer you to the public facility. But now it has been said that you can be taken to in case of an emergency. The emergencies, I think, have been listed in the regulations. They take you to a facility and then emergency care fund will take that cost wherever it is. And we have said again, it's both public and private. So you can be taken to a private facility in case of an emergency, and that will sort out some of the funds. The catch is the amount, you see. So there are specified limits, so to speak. But they say even in an emergency, when you go to an emergency, they'll still use your social health insurance fund until you exhaust it. And then after that, you can now tap into the EC fund, you see. So again, we go to our cough person. If the cough person is admitted to ICU, then they will now be in a level 5. They needed to have paid first.
Have paid. I mean, ICU.
And now the payment now. Probably what we also need in terms of payment. Again, the regulations gave, like they said an indigent. There is an indigent. An indigent is
can't pay, won't pay.
Can't pay, won't pay kind of thing. And I mean, so they say the indigent will pay, but 300 shillings. But that payment will come from government.
But then how do we identify them? Because
so
they
have proposed.
Test.
Yeah, they have proposed.
But then that's another step that we also have to undertake, right? And fundamentally, it sounds like there are many parallel processes that are ongoing, right? And it's fair, right? You don't expect to have a complete overhaul and it's just all good in one go, right? And it's an issue of timing. 1 year is not going to be sufficient, right? Maybe there's need for a dry run, right? But again, if people were educated and told we're going to start here, maybe we're starting with the primary care networks because we now have the community health promoters and whatnot, right? So we're starting off from here. We're working our way we'll get to level 6, the referral notes, all these things, they're coming, right? Because it sounds like it's a lot in one go and people are struggling to just digest the information. I think it's feasible over time. And if we break it down into pieces and say we're starting here, these others are ongoing, then maybe we can get somewhere, right? Because then what I'm thinking and what we might have to do in this podcast, we now need to start bringing the common man. People from county. We just have conversations because so far we've been having different stakeholders, and again, nothing wrong with that, who are telling us technical information, taking us through the different elements of policy, the meetings you attended, and I'm not invited.
You'll be invited.
I tell you. But we need to have those conversations because perhaps what we need to do beyond educating and saying this is where we are in this process is also highlighting the plight of the common man, right? And saying that last week or the other week we had here Dr. Ruth, right? Talking about maternal child health, right? And saying this is the situation. Because the mother who's bleeding out, right? Before we get into all the other technical information, what she needs is to be stabilized there and then. And if we don't have the heat stable, what is it? Yes, exactly. Right? We don't have freezers in where I come from, right? It's a problem, right? This mother is going to die. And perhaps the approach we need to take is saying that we start talking about maybe solutions, proposing solutions. Maternal child health, this is one, right? People who are diabetic, hypertension, right? And I say this because I'm always amazed at the capacity of innovation, not just private sector, NGOs at times, because you always look at, and I mentioned this, I worked for an NGO at some point, and our innovation was never something complicated. It was as simple as women were saying that it's hard for them to get to. It was actually a dispensary, I think. It was either level 2 or level 3, a health center. It wasn't a big facility. But them to deliver in a health facility was a factor of they cannot afford transportation there. And more importantly, there was also an element of education. These women were not attending their ANCs, right? They were not coming for the antenatal clinic. So we said, okay, as with the team back then, that how do we get the women to come to the facility in the first place, right? Not to deliver, just to get informed, right? This is where it's important to come, right? And the solution we arrived at, and this is after talking to the women in the different villages, right, was that if we give these women a pack of baby clothes that could potentially last them for 6 months as a reward, not even money, just as a reward, they knew one of the stress of a post-delivery, the financial stress of buying clothes and several other elements was taken care of because they'd get this package. So they had an incentive, right? But it was only by speaking to the people on the ground, speaking to the mothers, that they said, okay, fine, give us this, will come. And you'd find just the same way in Chamas, women would aggregate and say, you know what, we want our pack of baby clothes. And they'd get that information slowly, and eventually you saw the uptick, right? And maybe that's what we need to do, right? That maybe we start talking to people on the ground, people in counties, not even just people, even healthcare practitioners, administrators, nurses who are running dispensary, so that then we're presenting, these are the challenges. This is how they view from their end as potential solutions, so that as we're walking this journey, we're able to say we have integrated their voices, right? Because yes, public participation went on, but to me it still sounds like we're still at technical level.
So if they have chosen to identify, and it's not only indigents, they've chosen to identify your ability to pay using a tool called a means test. And the Ministry of Health has been given the authority to, it's actually stated that means test as from Ministry of Health. I mean, if I interpret it well, I probably think that the parameters that would be used would probably be guided by the Ministry of Health, although the Kenya Bureau of Standards has been doing that means test. So what does that mean? It means they come, they assess you. They come and say, this, she has a cow, she sells milk, so she has means, so to speak, and therefore her means annual income is probably 100,000. You see, and if they put that figure, then you will pay 2.75% of 100,000. So
on
they
top
were
of the housing levy we're paying. Anyway, carry on.
They were trying to. It's sort of like trying to spread to increase the pool of contributors, because they were saying previously, and not everyone was probably paying, and you'd pay when you are sick. So that's that. But if they find that, if they assess you and say, no, this one cannot pay, then they actually pay for you 300. Now, part of the problem the counties were having, county governments were having with that, is that you can come and declare everyone in a county an indigent, and the county government has to pay. So who takes that sort of load and responsibility? And they are looking at their revenues, and that might increase their expenditure. But some of the suggestions that were being taken is that, okay, there are already these people who are already been in some programs that they are being paid for. Can you start with those ones? There are ways of identifying that have already been used in the past. But again, that's in the discretion of the Ministry of Test. But they will see. When we look at it, we say, yeah, it looks a little tricky to do.
It's complicated.
It's a bit complicated, but they will figure out how to do that.
Kigondu, remember your story of Isiolo, right? I remember that story, and I feel like that's where we're going to end up, right? Maybe not at that level whereby there were only 2 nurses and 100. Maybe that's not it, but a state of what I think it's confusion, right? And maybe it will get better over time. Maybe as there's more education, it's going to be clearer, right? Maybe, we're just seeing the tip of the iceberg yet. Yeah. But I think just invite me for these meetings. I'm lost. I am lost. Or we start going to the counties. Because
So I think the approach I think they normally take, and we've seen a lot of that, is just enter into it and see how it goes.
Jump into the deep end.
Yeah, so let's see. Sometimes, of course, we think a lot. Of course, majority of the times, a lot of the times we are right. You are thinking, okay, if we start this. So, but because we haven't started, and then sometimes it may be difficult to actually even say, is it hard? Is it impossible? Yeah. It's for me, the big things include one, registering all Kenyans.
Between March and June, apparently. March and June. And we're queuing. I saw that.
Oh, there's a queue somewhere. That for me is challenging, and of course,
how
we
much
also
are you
give
paying to
input.
register again?
There's a payment. I don't think there's a payment.
There's no payment to just show up with your ID.
I haven't seen that.
There's no convenience fee.
I haven't seen that in the regulations. For me, again, if I was to advise them, they are already registered. I mean, we've been
registering all through.
Identity, ID, passport, birth certificate, and things like that. They probably would see how to integrate that. The second one is that one called the means testing. And they say they'll be doing it regularly because your means can change today. And then also in that means capability, there are also those who are maybe thought to be of means, but they are actually being supported by those of means who are being penalized more.
Exactly.
So for me, that is an area that needs to look for. And we also made a suggestion that they need to cap the deductions of gross salary, 2.75%. My suggestion was 5,000 shillings, which is, we said is an equivalent of a gross of
181,000.
Like 181,000. I mean, that's already. So already those people are probably the same ones who will be paying for the others. So a capping would be a positive sign for people because of the perception that, you'll be charged a lot of money.
Kigondu, we're running out of time, but no, I agree with you. I mean, it's complex. We can continue episode after episode discussing what are the technicalities, but perhaps the One Health Lens podcast needs to take a different approach, start proposing solutions, and probably highlighting where the need is most, right? Because otherwise, this is a long journey. It's a continuous journey. I mean, there are different voices we need to include. But it's a long one.
Yeah,
it really is.
But it's good. And I think even as we started in December, we wanted the common man to understand these common health things. And we actually now are seeing even the technical people also are getting into technical quagmires. Then you can imagine what the common man would go into. So, yes, this is a big potential of involving the users, and also going out there into the places where the action of healthcare will actually be taking place, for it to unfold in slow motion.
In slow motion. I tell you, I mean, thank you for that. This is us just telling you, starting next week, we'll be taking a new approach to the One Health Lens podcast. Join us next time.